Okay, good morning. Good morning, everybody, and welcome to the A.M. Buzz Edwards Lectureship in Clinical Education. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. And so with that, I've always looked forward to our Edwards lecture, and I'm going to hand it over to our Associate Chair for Education and Faculty Development, BJ Daniels, to introduce our speaker.
Thank you so much, Norman. Yes, so welcome everyone. It's my privilege to arrange this talk every year. And I wanted to begin with first a little bit about Buzz Edwards. Some of you in the room here knew Buzz, and I thought it'd be just good for those who maybe didn't know him to tell a little bit about him. So Buzz Edwards was born in Vancouver, Washington, but spent many of his formative years growing up in Three Hills, Alberta. He was a proud Albertan who went on to achieve the gold medal in medicine at the University of Alberta in 1950. He then completed postgraduate training in internal medicine and endocrinology at the Toronto General Hospital from 1950 to 1955. There he met his wife, Lorraine, and they returned to Edmonton in 1956, where Buzz began a long and rewarding career at the University of Alberta Hospital as a professor and consultant in internal medicine and endocrinology. Coming back to the University of Alberta Hospital, Buzz made many contributions to our hospital and university, serving as president of the medical staff of the University of Alberta Hospital, director of the Division of Internal Medicine from 1977 to 89, and was director of the residency training program in internal medicine from 1980 to 86. He was considered the physician's physician and consummate teacher of students and colleagues in medicine. His encyclopedic knowledge of literature and internal medicine was legendary. He will forever be remembered for his love of teaching, and he was honored to receive numerous teaching awards throughout his 44-year career. The former Department of Medicine head Garner King stated, "He was recognized in my days as the single most effective teacher and role model for undergraduates and residents." Now, we are really lucky because we actually have two of the family members joining. I don't know if they're able to turn on their camera and wave hi to people. We have Jane Griffin, who's out in Vancouver, and Marianne Edward-Berg, who's an ophthalmologist here in town. So thank you so much to both of you for coming and supporting us over the years. We really appreciate it. I'd like to now introduce our speaker. So Dr. Donato is the Associate Program Director for Internal Medicine and Vice Chair of the Department of Medicine at the Reading Hospital Tower Health in Pennsylvania. He completed his BS in biology at Georgetown University and then his MD at the University of Pittsburgh on an Air Force scholarship program. He has spent 27 years in medical education and took his love to obtain his master's in health professions education at the University of Illinois in Chicago in 2012. I graduated there in 2013, so Andy and I overlapped, and I'm going to date our chair to say she graduated from the MHP program in Chicago in 2001. So Andy's interests are in novel ways of teaching, direct observation, and the use of portfolios and low-stakes narrative evaluation to enhance personal relationships and promote growth in learners in medicine. I'm pleased to welcome Andy Donato. Throw it over to you, Andy. I will also say as we get started, Andy has a few questions that he's going to pose sort of in the first part. And so if you can throw that in the chat, and if you are writing in the chat, and for those in the room, you could just throw it out to me and I'll type it in the chat. If you're doing it in the chat, can you change it so that everybody can see it? Because by default, it goes to hosts and panelists. But if you're going to do it in the chat, do it so everybody can see it. All right, Andy, over to you.
Thanks so much, Dr. Daniels, for that warm introduction. What Dr. Daniels didn't say is I was slated to come meet you all in 2020 May. If you remember what happened in 2020 May, COVID decided that that wasn't going to happen. So I'm very sorry I didn't get to see your hospital. And I'm honored to speak in with the Edwards lecture. What I didn't hear mentioned was he was the physician to the Prince and Princess of Wales, the Pope, and the Queen Mother, which is a pretty impressive biography in itself. and a doctor's doctor and a teacher's teacher, which is very big shoes to fill. So with that, thank you, and I'll start. As many of you, I am an internal medicine teacher, so my disclosures are pretty short and sweet. By the time I'm finished this morning, I'd like you all to at least know a couple key history points in CBME and the movement. I'd like you to describe 2 tenets of what an effective assessment system is and does. And I'd like you to think about just one potential modification to your own system and consider that. In regards to a timeline, I'm going to give you a short walk through a little bit of history. I'm going to talk about what I believe are the key components of an assessment system in 2024. And I'm going to pull it all together with how we actually do that in real life. So I want to start out with a provocative question. I want to ask all of you in the room, why do we assess? What is the point of performing assessments? Why do we have to do this? What's the rationale? What's in it for all of us to do this? Can I ask you all to chat? And I'm going to put down comments. So I'm actually now I'm even sadder that I didn't get to meet all of you. The first answers and a very strong theme here were about the learner, and I love that. I'd like to sort of summarize a lot of what I've got here, and I'll come back to in terms of we have to determine achievement, right? We do have a responsibility, as someone said in the chat. You can't let your learners leave because the government has asked you to tell them who is safe to practice, right? We have to set a bar and make sure people cleared that bar. Similarly, we want to try and figure out who's having problems, right? As I like to say, 10% of your learners are 50% of your headaches, but they're the ones you really want to put the efforts into that need the extra help. Most people, they're turnkey, right? You put them in the right places and they learn what they should learn. But I loved this, that there is a very, very important reason we do this, and that's to guide learners. And I'd like to make the argument that that what I'd like to talk about is how much of that can get lost when we have 3 competing agendas. So the tensions between these goals, one can drown out the others. And I think we have to, as teachers, be very, very cognizant of this. I'm going to spend a while talking about that tension this morning. I'm going to do a brief deep dive into history, and I'm going to start a little bit comparing car makers and doctor makers. So in the early 1900s, cars were essentially all a one-off. Cars were made by hand, and every single car was different. If you've ever watched shows about the early cars in 1900 in Britain, all of these very wealthy people had a driver. And you'd think, well, why would somebody not want to drive their car? It looks like a lot of fun. Those drivers were actually the mechanics, and they had to fix cars that broke all the time. They also were master craftsmen. Every piece was built by hand. Something was broken, had to be crafted by hand, and they handed down this skill person to person. So if you were an apprentice, you would learn from a master craftsman and become a master only when that master said, yes, I have imparted all of those skills. In 1900, thank you very much, by the way, Canada, for Osler, graced us at Johns Hopkins with his presence and basically started the first real residency program in America. And he had very much of a master apprentice type model. He brought in residents, and what were residents? They literally lived at Hopkins Hospital. They were raised by Hopkins. They were fed, cared for, and then they ran the hospital. They got a staff job when someone died, retired, or left, or they went to a different hospital. By the way, Osler hated that Hopkins put in a entrance exam later on because he said it drew the wrong type of resident, and he wanted word of mouth and somebody that he believed in and trusted. So that master apprentice model has had quite a change for good reasons. 2024, right now, the car you all drove to work in is an incredible model. It's a computer on wheels. It's incredibly sophisticated. And the car that came off the assembly line just before yours is probably nearly identical to yours. Any change in any car, they stop the line, they use a QI process, they fix it, and they're able to very, very efficiently churn out wonderful vehicles at exceedingly low price given the technology that's in them. However, in 2024, we have very much of a Taylorian type model in medical school teaching. We are running a very diverse group of people down an assembly line out to very, very different areas of medicine. How do we assess the output in that group? How do we figure out how much variance is error and how much is just growth? How do we put all this together? I think it's a critical question as we come up with assessment systems. So let's fast forward a little bit to this guy. So the 1960s is often seen in medicine as our heyday. Why was it? Because we were coming up with ridiculous inventions left and right, and society wrote us a blank check. They said medicine is going to figure out everything. Whatever they do is fine. Every other field had a lot of oversight. We did not. We were just believed by society that we are smart enough and we're better people and we're going to figure it out. And the lack of oversight was an amazing gift to all of us. Can anyone in the chat tell me who this man is? If I had candy in the room, I would be aiming at the person that could give me this face. BJ? Oh, who said that? Wendy Johnson, well played. This is Tommy Douglas. Tommy Douglas, as a young boy in Winnipeg, nearly lost his leg to osteomyelitis because his parents could not afford medical care. He's an interesting guy. He was a champion debater in college, influenced by the social gospel movement. He wrote his college thesis on eugenics, of all things. He endorsed the theories, but then later opposed them as a prime minister. Why am I talking about Tommy? In 1947, as the Social Democratic Premier of Saskatchewan, he set up the first universal health care in North America, covering all the citizens of Saskatchewan for inpatient care financed through taxes. 10 years later, in 1957, the federal government offered a national health care program called the Health Insurance and Diagnostic Services Act, paying 50 cents on the dollar for each dollar a province spent on healthcare. In 1959, Tommy Douglas proposed a universal publicly funded medical insurance coverage called Medicare. Thank you, we stole that too. Medicare was strongly opposed by the doctors of Saskatchewan, who started a committee called Keep Our Doctors and organized a general strike on July 1st, 1962, the day the program was set to begin. 90% of the doctors closed their doors to all patients. The U.S. and UK had to backfill doctors. The strike ended when opt-out provisions for the fee-for-service protections and for the private practice model were added, adding extra billing as a compromise called the Saskatoon Agreement, in which doctors would become part of the system as publicly paid but self-employed with minimal engagement and minimal accountability. By 1965, federal Liberals announced a 50-50 cost-sharing plan known as National Medicare, with provincial plans that established comprehensive medical insurance. However, for the next 10 years, extra billing fees grew and limited access for some patients. In 1984, we got the Canada Health Act, unanimously passed by Parliament, explicitly banning all extra billing and establishing criteria for transfer payment with eligibility and penalties for violations. As you might imagine, the physicians who were happy with the Saskatoon agreement pushed back, culminating in the 1987 Ontario physicians' strike. Strike leaders compared the ban to concentration camps and decisions to work as similar to state psychiatrists in Russian political prisons. Doctors closed their doors for non-essential surgeries. 52% of the doctors participated, but public opinion polls went badly for the doctors. Stories of patient maltreatment gave the physicians a black eye. The Toronto Sun wrote, quote, "In public opinion, the withdrawal of services was not motivated by noble ideals of autonomy or equality. Instead, physicians' motives were seen as selfish, predatory, and duplicitous." Physicians had fallen very far since their heyday. Faced with what they believed was a serious black eye and a decline in trust, Donald Wilson and Brian Henderson started Educating Future Physicians for Ontario, the EFFO project. They met with educators and citizens and asked them what would they want out of their doctors. Then they devised strategies to add these to the curriculum through the RCCP. The National CanMeds Framework, introduced in 1996, was imitated elsewhere and in both homegrown and copied versions in the US, Western Europe, and Australia. Yes, once again, we do copy you. The idea was to use input from physicians and patients' needs and ensure that physicians were prepared to thrive in a new healthcare environment. Specifically, they wrote, they were trying to offset the forces of patient consumerism, government regulations, financial constraints, information on the internet, and exposure of medical knowledge. The revisions led to Competence by Design framework rolled out in 2017, which breaks down the 7 roles into 130 elements, 28 key competencies, and 125 enabling competencies that is supposedly better able to translate roles into a usable framework for day-to-day educators. And what's that look like? I think you're all very familiar with this. The features include clearly articulated competencies aligned with social needs, spelled out in EPAs, that the competencies are intended to be sequenced progressively from one to the other, a continuum of more difficult challenges as a learner achieves the prior ones. Your learners should be assessed in authentic workplace environments. The push is to leave training when you're competent, not based on time. Through this model, it's intended that real-time feedback should be given continuously through low stakes and spelled out using the EPAs to structure further learning. Finally, the goal should be assessment for learning, not of learning. The system should make this, the system goal should be to make this, the learners game the system to become better doctors, but make them want to learn and put them in control of their learning as much as possible. They highlight the benefits of a portfolio to achieve these ends. So where's the future? The CanMeds group is coming back together to reanalyze their work and redefine their theories. They intend to incorporate theories of adaptive expertise, anti-racism, the clinical learning environment, social justice, planetary health, and virtual care into the 2025 framework, and the flower is going to get a little more crowded. So where are we in 2024? In UME in America, the test is king. Step 1, a test designed for pass-fail, has become the holy grail and the golden path to dermatology and urology. A cheating scandal cast a wide net over entire countries in 2024 over it. Test prep companies and question banks trump any classroom attendance, where attendance has fallen in many places to below 5%. And step 1 had to be changed to pass-fail, while step 2 now assumes its lofty place. The OSCE replaces the physical exam class, and answers on checklists are more important than reasoning or going to sessions to learn it. The ACGME wants 20+ milestone performances on 6 competencies every 6 months, and medicine residents in Canada need to meet basic standards in directly observed activities in order to progress. with summative checkoffs, potentially obscuring important lessons. The tests dominate, and assessment drives learning. So with that, I want to cover what I think are the unintended consequences of CBME. I'm going to break it up into 5 groups. One, it matters what happens on the ground. So that an Army term is what happens to, with the boots on the ground is what matters, not what headquarters dreams up. There are definitely dual and conflicting roles of summatively oriented systems I'm going to talk about. Rating as a social construct with a nod to Dr. Gingrich. Teachers and what gives us meaning, and what I would consider reductionism and the checkoff, finding bad apples versus growing all apples. And I'll cover these one by one. I love how this argument was so eloquently made by Hatal and Ginsburg. As you can see, by the way, all of my med-ed heroes are Canadian. No matter what you dream up from headquarters, the boots on the ground, how the soldiers carry out the orders is critical to what's asked. EPAs were originally designed for OBGYN procedures in which there's very little deviation from the accepted procedures that occur in a linear manner. Push, ma'am, push, turn your shoulder, grab the head, and so on, like I know how to deliver a baby. Anyway, the language of entrustment generally comes easier to proceduralists who can observe who can and who cannot and steadily grant more privileges to those they feel comfortable with. Internal medicine, on the other hand, has procedures, for instance, guiding somebody through the admission process, managing them on the floor, managing as a rapid response to discharge, that is often done over an extended period of time, sometimes days and weeks. Many of it's performed by other teams, other specialists, case management. And the language of entrustment is just not something that we are entirely used to. We're much less comfortable with that than comfort. I am comfortable with that resident managing a differentiated ward patient with indirect supervision. It's a better fit for our ethos. And most important with all this is context. Context is everything in medicine. The resident dragging you to the bedside to give him a 5 on an admission in a simple cellulitis in a 40-year-old does not help you determine how he does with an undifferentiated dyspnea in an immunocompromised patient with a hypercoagulable state and a language barrier, because context is critical to understanding competence. My mentor, Lou Pangaro, brings this point up very well in 2 Cheers for the Milestones, which I cited below, commenting on the complexity of the US version of this, in which he says, quote, "The time it takes to learn and use a framework with consistency is a critically, though poorly studied factor in utility of assessments. It's what happens on the ground that matters." A few key concepts have emerged in the study of assessment systems. The researchers in the Netherlands have a keen eye on the concepts that summative and formative exist as a dichotomy. Systems that are summatively focused will change a learner's behavior. This will trivialize learning. Work from Bach in 2023 showed the more summatively oriented assessment system was, the more learners seek grades when easy tasks arrive and avoid feedback. Kevin Eva talks about this concept using the phrase, the psychological immune system. The docs that are on the weaker side don't want to get exposed. The docs that are wonderful are willing to do so, but they don't need the feedback. Very nice work performed here by Damian and Daniels. Looked at motivations for using EPAs. And what they found is very similar. Only 9% of those surveyed said the EPAs were either important or extremely important to their learning. Is the message lost in the grade? More importantly, and I hope I leave you with this, it is the effects of learners on instruction. This wonderful work by Valerie Shute in 2008, I frequently quote. She had 3 groups of learners. In one, she gave only formative feedback to papers written, and she saw significant learning gains on repeat papers. On a second group, she gave just a grade. She saw no difference in performance on repeat papers. On a third group, she gave those grades plus her wonderful formative comments. She saw no gain. Think about that. Take that in. Summative drowns out teaching gains. The grades suppress your brilliant comments. So what do? We know that formative and summative balance is critical. We must at some point determine competence, as all of you have clearly pointed out. without losing our primary goal of imparting a lesson and teaching the learner. Remember that summative will drown out formative unless the grade is deprioritized. Too much summative, it becomes about the grade. They won't reflect, they won't learn from the exercise, and both the teachers and the learners will resent doing it. Too much forced content or structure makes the learners too confined. The learning lessons will be drowned out. It'll be a tick box exercise, and it'll be the 100th thing they do in a day they get through 15. However, there must be some balance with the summative. The risks of all formative, they will say, well, I don't learn that way, and they won't do it. They have other competing agendas. It must carry some weight or won't be prioritized. What I say, consider firewalls. Make sure the feedback they're getting is separated as much as you can from the grade to preserve authenticity. Keep the process as transparent as you can through your CCCs and qualitative assessment of narratives. And I'll talk about that when I get to my second half. Andrea Gingrich has this wonderful way of looking at evaluations that involves their social aspects, specifically evaluations of human activity by other humans is intrinsically tied up in the relationship between those humans. How hard is it for someone to give a bad evaluation? How does one do that without being personal? Humans are terrible at using scales. We cluster all of our scores on the high end. No matter how many behavioral anchors we use, raters still see a 1 to 5 score. Despite everything in EPA is to use behavioral anchors that took away the numbers, there's a lot of concern that raters and those being rated see a 5 as the goal. That's likely because human factors are inextricably intertwined. Words, narratives help you describe and capture context, difficulty, and effort that an evaluator and a program could understand. Variance can all be signal, should be qualitatively assessed as opposed to assuming that variance is error. Something not talked about enough is your teachers and what they find meaningful. Physician teachers, such as myself, have chaotic lives in which we accomplish only a small percentage of what's in front of us on any given day. We can only accomplish this through deprioritizing lower value tasks and prioritizing those that give us meaning. Many of them, me included, that includes paperwork, writing notes, and coding is much farther down on the list of things that give me meaning. What gives me meaning? Connections to my patients, connections to my learners. The more that our assessment systems are tick box exercises, the more it becomes devoid of meaning for our teachers. Those teachers are still teaching, observing, and practicing medicine, how they know how to do it best. The Buzz Edwardses are still doing their work because it gives them joy. It's just uncoupled from assessment activity. How can we harness assessment to capture the lessons while deprioritizing the summative components? For those of you curious or that actually have this tattoo, this is the unilome, which represents the path to freedom, spiritual awakening, and contentment. It's intended to remind us that our journey will not be quick or straightforward, but we must stay focused on our goals and derive the meaning behind those goals. Last, EPAs and the checkoff. This is my 4th child, Leah. She turned 16 this past January 1st. Similar to Canada, that's the driving age in the United States. The first step in getting a license is to pass a knowledge test of the rules of the road. Leah had to go through a 70-page book and pass a test that she knew what to do when the big red octagon sign that said STOP on it showed up. She took the test in January and was fortunate enough to be able to pass it on her first try. Would anyone like to guess whether she reopened the book when she got home? It's almost a silly question. None of us ever did. We passed the test and the book is no longer needed, right? Does Leah need ongoing feedback? I think the obvious answer is yes. On her first drive around the church parking lot, she hit a garden with a statue of Mary. Fortunately, she did not fall over. Leah will need various levels of feedback as she learns how to operate the vehicle, whether she wants it from her dad or not. But let's apply this to internal medicine. Although we are evolving forward, previously in America, once you passed a board exam, you never had another knowledge test. They now grandfather you in every 10 years, but we all know that doesn't work either. How about the resident you just signed off on, quote, performing a history and physical? Does that resident need continued observation and feedback even though they passed? Saying someone is competent to admit a patient with pneumonia in 2019 does not say they'll have any idea what to do with COVID 6 months later. The concept ignores that ongoing observation is critical and that knowledge decays with time. Let's talk about the role of professional development with the lens of Dreyfus models and deliberate practice, just so I can talk about one America. So the Dreyfus model helps us understand the expertise along the continuum. Novice is where you were when you started medical school, not allowed to work independently. You became advanced when you got to the wards and we could watch over your shoulder. You eventually become competent where you could work with indirect supervision as an intern and a resident. Eventually, we got enough confidence in you that you were able to work at the proficient level without supervision. After graduation from residency, you become an advanced non-expert, practicing on your own, supervising others. What we do know is that people's skills decay, as you can see in this graph. The question is, how do we make them lifelong learners or adaptive experts? The way, from years of study of experts in the field, is something coined by Anders Ericsson, just died unfortunately, called deliberate practice. What Anders did is he studied tons of chess players, musicians, Dr. Daniels, people that were experts in sports, medicine, the law, and said, who are these people that actually became experts? And what he said was, the difference between those that decay and those that continue to grow is this thing called deliberate practice. The components of it are practicing at levels that are challenging and intense on a regular basis while receiving ongoing feedback. He says that 70% of the difference between experts and non-experts in the world of chess is explained by this, but it requires ongoing coaching, reflection, and practice, not checkoffs for bare minimum competence. Reductionist structures threaten this on a teacher and student level. Systems designed to check somebody off for bare minimum, to look to identify bad apples as opposed to growing all apples, will only get you that. How do we ready them for the challenges that we don't even know about yet for the next pandemic? They have to be in a situation where they're continuously accepting feedback and finding places they need to grow on their own as self-directed learners. Let's now shift gears and what I consider the key components of effective assessment systems. I consider these 6 tenets to be critical. First, design your assessments to prioritize learning. That is this assessment for learning, not of learning. Don't overstructure your tools. You will trivialize the learning. I love the Kevin Eva, learn to love the collective, the wisdom of crowds. Get as many views and contexts as possible to reduce rater bias. See formative summative as a continuum from low stakes, a WBA, to high stakes, summations of those, 360s, end of month, multi-source feedback, and use those for decisions to promote. Make sure learners have a stake and ownership in the process, and most importantly, rely on narratives to collect and assemble and holistic methods to summarize. Let's do those one by one. Assessment for learning is prioritizing the learning. Get narratives and downplay or eliminate the scores. High stakes, infrequent tests with no learner feedbacks are classic characteristics of assessment of learning. The classic USMLE is a great example. Very high stakes, infrequent, no formative, assessment drives behavior. Learners memorize test banks and don't come to lecture. They understand single associations between disease processes, but not how to think. As I said, in the US, classes that seat 300 have 3 to 5 occupants. The rest watch at home at 2.0 speed, so they have more time to memorize question banks. Students routinely cut their physical diagnosis classes to memorize OSCE checklists. What if the assessments themselves and gaming them to overcome them drove learning habits? What if we actually measured what we pushed them to be better doctors? Van der Vleuten argued that an effective program assessment should drive the learners to what we want, which are lifelong learning habits. Another risk of competence-based education is the urge to add structure to forms. And this is the leaders and are responsible for this. Adding multiple EPAs, adding milestones, adding grading ranges. We all feel like we can get more out of the observer by adding these things, and we don't. This trivializes the learning. As we As I talked about with the Bach article, the more summative, the more learners will seek out grades and avoid feedback. Shuti and feedback, remember that grades are terrible information carriers. They dilute, if not completely obscure, your feedback. Assessment for learning, prioritize the learning, get narratives, downplay or eliminate the scores. Next, you need to control subjective bias by increasing graders in context. Use the wisdom of crowds, as Kivaniva would say. But aren't all these tools too unreliable for high stakes? Isn't that what we learned? Look, we all know the multiple choice question is an incredibly efficient way to get a reliable answer, but its reliability comes from efficient and broad sampling of context. If right now in the room, I passed out a single board question to all of you and told you that your board certification depended on the answer, you'd tell me I was crazy, right? It's partly because no one question can sample enough of our jobs to tell the competent from incompetent. Similarly, because you can efficiently ask 250 board questions in 4 hours, you can generally sort out who has the knowledge and who doesn't pretty quickly. But what about all these other tools? Weren't we taught that these are all too subjective? Yes and no. It's a matter of sampling. Individual questions take significantly longer when you talk about a direct observation, an oral exam, or a patient video, but given enough time, these all cross the threshold for reliability. If given enough time, because you get enough sampling. They're dependable enough to be used for high stakes decisions. The key here is reliability is dependent on sampling, the stimulus, far more than the instrument used. The key point, get as much sampling of work as possible. And as Kevin Eva would say, get as many eyes as possible. I believe I'm a very good observer, but I observe a lot of the same stuff. I need Lisa Moats down the hall to pick up the subtleties of the engagement in the encounter that she always does. She's a consummate introvert and sees things I don't see. It's the wisdom of crowds that gets you the full picture. Get as many eyes as possible. Next, balance formative and summative. Put the formative consciously to the foreground. Van der Vleuten and colleagues strongly advocate a system of assessment that collates many low-stakes events to make sense of higher stakes decisions. Feedback to the learner should be your primary focus. Teaching and observation should be very regular. Errors should be fed back to the learner for continuous improvement. See formative and summative as a continuum, from the low single workplace assessment to the very high, which is a collation of all of the above. Next, learners must believe in and guide their own learning to become lifelong learners. Learners should initially have scaffolding through mentors to help them, but eventually should direct their own. I personally believe that portfolios are a great way to do this process and gradually scaffold them to take control on their own. And lastly, humans are terrible at translating human activities to numbers, as Gingrich has told us over and over. Numbers don't translate meaningful information to learners, as Shuti tells us. Your teachers and your learners understand words. They capture critical context. They show us nuance. And yes, with a little bit of training, your teachers can interpret them just as well as they can interpret numbers. Use qualitative methods to ensure reliability and validity of findings, member checking, prolonged engagement, rich descriptions, and audit trails to make credible high stakes decisions. All right, I just told you very, very high level stuff. Let me tell you what we do on the ground in my internal medicine program to make all this happen. I'm going to touch on 5 features of our assessment system that I think are critical to make sure the lesson is imparted. 1, we use a scoreless, universally applicable direct observation instrument. 2, we built an advocacy-based CCC that gives continuous feedback to the learner. It's all about the feedback. 3, we have a very vigorous one-on-one mentoring and coaching process that we are very proud of. 4, we use a professional development focused portfolio. 5, we use synthetic summative judgments using educational experts to report to national bodies. I'm going to cover each of these one by one. 1, direct observation. This is probably one of the most critical pillars. In 2004, we developed and tested our own direct observation tool. It's now performed by 90 different observers in 8 specialties. We published on this in 2008. The tool has broad, non-directed sampling. It can basically be used anywhere. The instrument basically has prompts for best practice of communication, applied knowledge, and presentation skills, but it's all free text and it's not scored. It's also EPA agnostic. Contexts are chosen by the teachers or occasionally encouraged or sought after by the learner. 5 years into use, we did have a rating scale that we dropped. It was just behavioral anchors, but everyone saw them as a 1 to 4 scale, so we bailed on it. 10 years in, we made it fully electronic. Learners receive action plans electronically. They're asked to reflect on them before meetings with mentors. They're asked to comment on general trends and next steps as a result of feedback given, and then those are scaffolded by the mentor. Let's talk about what you've got to get better at. Let's talk about next steps where you need to be observed. Summative synthesis and milestone ratings are performed by a synthetic review of all findings that I'll talk about later. So this prioritizes the learning lesson and de-emphasizes the grade. The second arm we do differently is our advocacy-based CCC committee. So the clinical competence committees are designed to have core faculty vote on achievement. US CCC designs have members review resident performance to date and rate progress, checking boxes in milestone categories. Because much of our data is purely narrative, the CCC has to have a comfort with qualitative methods and needs significant faculty development to do this. Fortunately, all of our faculty are clinical, meaning dividing meaning out of words is something they do frequently in patient care. Here's the process. The members of the CCC review progress. Then the resident's faculty mentor actually presents the positive case for the resident's competence in their defense. A discussion ensues back and forth and what the resident does well and what they need to work on for growth. The mentor then takes that entire conversation to the resident and talks about what they need to work on, where they need to be observed, and talks about their own plans for the next 4 to 6 months and where they need to grow. Helps them build a study plan. A critical portion of this involves direct one-on-one investment with a mentor. We assign mentors at the beginning of the year based on interests and commonalities. The mentor reviews direct observations for trends. They can share reflective writing. They regularly schedule meetings with the learners and review recent evaluations. And most importantly, they review residents' reflections on where they're going and where they're growing. The mentor represents them at the CCC. Mentor meetings require 2 to 3 hours of work by the resident using a structured portfolio, which they invite their mentor to have a 7-day view-only access, and usually an hour of prep for me, the mentor. Meetings are about high-level topics, not did you go to conference, but their life plans, how they balance the rest of their lives, things that are burning them out, how they're working on subspecialty plans and their research, where they need to grow, and often marriage and children stuff. All this is scaffolded by the use of a professional development portfolio that I'm going to talk about next. So 15 years ago, we piloted an online portfolio to help residents reflect on their growth. This is a screenshot of the entry page. The portfolio was intended to add structure to the mentor experience and get them to critical conversations. I often refer to this as the canvas for critical discussions, things they're burning them out, analysis of their deficiencies, things they're working on, their goals and dreams, critical incident writing. And we published on this in 2012. Lastly, in order to bury the summative components, we heavily rely on narratives and formative feedback, but assemble those narratives for summative review using experts. This is in contrast to most programs in the US who rely on direct summative decision-making at individual encounters. They basically grade them on the fly in the field. As I've argued, the summative blinds the formative and obscures the message. I also believe that any one encounter might contribute to an overall summative decision, but shouldn't be made without consideration of all of the data points and without its context. For that reason, we use expert synthesis for our summative decisions. As typical for many programs, we have CCC members who give high stakes promotion and graduation decisions only after a thorough review of the entire body of work and input from their mentor, making the positive case for their competence. What's unique to us is the program director and his assistants, that's me, map that then to the national reporting guidelines and basically tell the governing bodies where a resident is on their path through the milestones. But it's a synthetic summative review from experts that understand the implications of the milestones for the residents. All right, that all sounded pretty great, but you all know if you put a system together, there's always challenges. My direct observation tool requires some training orientation as to its use. Specifically, we have 90 physicians who perform these, most of whom have no formal education training, and many of whom ask me the question, I already fill out an end of month evaluation, so what good is a direct observation? 5 to 10% of my staff turn over every year, and they need frequent feedback for their direct observations. When we started this program more than a decade ago, I had a wonderful chairman who she suggested that we created an incentive plan we'd be proud of, and that would drive academic production and educational throughput. That included pay for performance for direct observations in a financial incentive. Unfortunately, we had a financial crisis 2 years ago, and 85% of our incentives were shifted to production, which, guess what, took a big hit on our direct observation numbers that we're recovering from slowly. We're fortunate that we've been able to keep trained faculty who have significant expertise in qualitative measures. We keep them and rotate them through the CCC so they get frequent feedback. But my faculty development usually revolves around qualitative methods and understanding words. Rudolf Virchow, the father of modern pathology, once said, physicians are the natural attorneys of the poor, and social problems should be largely solved by them. I believe that many of you in this room teach this in all of your day-to-day actions. I would argue the goal should be to find our best teachers, find this generation's Buzz Edwards, and let them teach. On a national, international level, it's up to our national institutions to change the perverse back-end incentives that pull physicians away from this noble calling and toward money and power, which is much worse down here than it is up there. And I don't believe that simply changing to reductionist summative assessment systems or Byzantine curriculum changes will in themselves redirect the next generation toward our calling, or any more than I believe the effectiveness of the US K through 12 drug resistance education or any dating advice I got from my priest. You know who knows how to teach, let them do it. And while they're doing it, let them tell you what they see. That's as controversial as I'm going to get. Features of effective assessment systems. Design assessments to prioritize learning. Assess for learning. Make them game the system to be better doctors. Use flexible tools that prioritize the formative. Reduce bias by the wisdom of crowds, as Kevin Eva would say. Lots of eyes, lots of contexts. Balance the formative summatives at continuum. Put the feedback in the front. Let the learners own the process. Remember, in the end, they have to be self-directed learners. Their next COVID is coming. And use words. Words are how we express nuance, how difficult a patient situation was, the language barrier, everything. Those words will capture it, and you'll be able to interpret those words as the program. To go through the chat when we first started, I love some of these comments. Drive learning, inspire, assess, promote growth. Yes, we've got to meet the standards, but it's so important that the learners not get lost in the process. Improve quality is great. All of these that you gave me in comments are wonderful. And yes, Tommy Douglas is greatest Canadian. I like that too. My conclusions. I suggest that we assess for learning. What I'd like you to think about now is that reductionist mindsets currently prevail. Human behaviors such as competence don't conform, or they're not translated easily into numbers. Use the system you create to enhance the learning experience. Collect multiple low-stakes narrative-based recordings and summarize them using experts. If you keep the human touch alive, it will keep you coming to work. The practice of medicine can be incredibly rewarding, but is also hazardous to your health. Keeping that human connection strong will allow you to save them. And in the process, I believe your learners will save you. BJ, with that, can we conclude and hear from your audience?
Thank you so much. And so thank you, Dr. Donato. We ended up hitting 115 online, and we've got easily 20-25 in the room. So yeah, so put your questions in the Q&A. but maybe I'll actually give an opportunity, sorry to put them on the spot, if Jane or Marianne had any questions or comments as our distinguished visitors. You can say no, that's totally fine. I just thought I'd give you the first opportunity if you had any questions or comments.
Hi, Dr. Donato. Yeah, this is Marianne Edwards, and I just actually typed a little message into the chat. I don't really have any questions. Certainly, it's an insightful review. We use a lot of the same techniques in ophthalmology for teaching and evaluation, formative and summative. And today, in fact, is our resident research day, which I will be turning to right away for a full day of lectures. And some of the residents are doing some presentations on AI and its use in ophthalmology and in teaching. So, you know, I'll take your comments forward this afternoon to my own department. So thanks very much.
Yeah, AI is the buzzword in everything now.
Yeah.
And what it does in education is going to be fascinating. What it does in my street medicine outreach and how soon I can actually point a camera at an eye on the street and tell whether that person has to go see you I'm very much looking forward to the technology that's possible with image interpretation.
Yeah.
So please keep working on that. I need it badly.
No problem. Thank you. Take care.
So I'll give the chair the prerogative in terms of the first question. Yes.
What a tremendous presentation, and you know, you so nicely outlined the many challenges that we've had with CBD and, you know, both learner as well as faculty wellness and burnout, I would say. You know, I mean, multiple factors, obviously, the pandemic and all the other things, but I really liked your message at the end in terms of letting good teachers teach. But I wanted to ask you maybe something outside of your expertise in terms of, you know, graduate education, and just talk a little bit about CME, because one of the things that our colleges, both our Alberta College as well as the Royal College, has struggled with is maintenance of competence. And you talked about deliberate practice.
Yes.
And, you know, I think a lot of the tools you talked about would help in terms of our learners developing how to, you know, develop their own learning plans and things like that. But, you know, can you take it to the next step and help me out as a chair to think about how we promote that as a faculty development tool, you know, maintenance of competence sort of tool?
And so you were talking about not teaching competence, you're talking about clinical competence among the faculty. Is that correct?
Yeah, exactly.
This is a great question. So the people that I think are doing it the best in America is anesthesia. So they realize that we have to keep up, and they essentially they've done away with their year-long 10-year whatever test, and every 2 weeks they actually send an important anesthesia question that everybody has to answer, and that they have to keep up with. And I think some continuous reading is critical. Now that helps medical knowledge. It doesn't do the rest. I will throw back, and I didn't get to talk about it enough. I am now one of the old people on my hallway, which is sad because of the people that actually taught me and guided me. I need that, and I need it from younger people. One of the things that's been very exciting over the past 10 years that we do here is every single week that I'm on service, coming up next week, I will be directly observed by a colleague who will actually look at all of the teams, watch a snippet, watch 15 minutes of walk rounds on everybody, and then bring us together for just 10 minutes to talk about a single topic based on what they saw. I do this as an observer, and I am also observed. And I'll tell you, it is very interesting to watch, beyond the topic, to watch the teaching techniques. And I think as faculty development, the best things are on the fly stuff. And I absolutely adore it. And my colleagues that are 3 years in that I just taught see stuff in my style that I just don't see. And I think that feedback is wonderful. We use a completely not scored, completely not named device that I keep and I go through at the end of the year, and I pick faculty development topics based on essentially what's written, the narrative comments. So I would say you need eyes. You need to get it regularly, and people need to be to get comfortable with, this is for my own good. I don't know if I answered the question, but that's how I do it personally.
Yep, you did. So our next question is from Tom Jerkathiel, one of our neurologists. How long does it take for the medical education system to respond to social forces and needs or to adjust its direction?
I think Tom can look at this the exact same way I can, and with glacial pace. Is that fair? I mean, if you look, this move from every person for themselves to we need a system of healthcare, that was 60 years. And the move to this CBME has been we've been at it 30 years. We move slowly. We move slower than our careers course even go. But inside that system, I still think we can make a lot of difference. I'm saying as the teachers, those students still want to learn from you, and there are day-to-day things you can do for them to help them teach and connect you to the meaning of why you come to work, patient care, and to teach. And I'm saying for us, the leaders, I think we need to capture you and your lessons as best possible in ways that don't mask that lesson. And if you tell me exactly what happened on the wards, that somebody was completely lost in hyponatremia and couldn't put a volume assessment together, and they are a third-year resident, I know they're in huge trouble. If they're a third year that just started with Drexel with me 10 minutes ago, I know that that's very, very common, and I know where to send them. I need that information captured, and I need you to teach.
Next question is from Sarah Troster, one of our rheumatologists and program director for rheumatology.
Sure.
How do you use OSCEs in your program? What role do you see them playing in a system of assessment along with EPAs?
That's a wonderful question. So we actually right now, I have a program that is that gets 15 interns per year. About half of them are internationals and know nothing about the US system. They often come from systems where even how people care for patients is very hierarchical, and they're not used to asking the patient what they actually think about the treatment. We start within the first 2 months with an OSCE with the residents, essentially just to get a look of who we need to do more work on. What I do with that, I place no value in patient scoring and checklists. I actually make the residents watch 4 of the videos, and their mentor watched 4 of the videos, and I have them come back together and talk about what they saw. I have the residents reflect on it to figure out what they need to work on. So it's much more, and if you haven't been videotaped yourself, by the way, it's a humbling experience, but it's great to have them see what they do well and not so well, and actually change for that. So that's how I use it. It's once, just when they come in, as a litmus test for what do I need to work on.
Maybe we'll take one more question. Richard Caviccioli is one of our neurologists. You can just tell me it all.
Partly get addresses a lot faster, but how to incorporate, because I think we learn a lot from our patients, we get feedback from our patients. How does he incorporate it?
So the question is, how do we incorporate patients' views into assessments?
Ooh. So the last person gets to stump the speaker. Thank you so much. That's a really good question. I loved that when you guys built your competency system, that you actually went to patients and asked them what they wanted. I don't know that that's often done. We are very frequently in America, we get a ton of feedback from patients. Usually they're very reminded to tell us when they didn't like the care, but as a group, we probably need a lot more of what does the system need to do for the patients, because we have a very, very expensive system here, I believe, that lets down a lot of people. So work in progress. Thanks for the question, and thanks for stumping me.
I think maybe I'll just make a comment to everyone listening. Based on what you said, Andy, it definitely resonates that we all struggle where we're doing these EP observations at the bedside, and our learners are too fixated on the scale, whereas most of us just want to give feedback. And yep. I try very much to downgrade the importance of that scale. Like, whatever, I don't really care. how do you think you did? And honestly, I almost just give them whatever they think they did. So for those of you who are in the room that are going to work with me next week, it's fine.
Go to VJ, get a
I
5.
care about the feedback, what you did well, what you need to work on. So again, thank you so much, Dr. Donato. Oh, one last comment from Jacques Birmingham, endocrinologist. Our formative years also affects our perceptions of language and potential biases. Videotape is from the 80s. It's digital recordings, Dr. Donato.
Oh, well.
All right.
Yeah,
Well,
that I was
thank
from
you.
the 80s.
Yeah. Thank you, Dr. Donato, for fantastic rounds. We really appreciate it. And again, it was nice to see you again. Thank you. You're doing some great work there, and
Thank
look
you.
forward to continuing these conversations.
Hope to have it in person someday.
All the best. Thanks, everyone.
I guess.